Dr. Natalia Zarate-Lopez started her training in gastroenterology in Spain, and then became interested in neurogastroenterology. Moved to Canada with a fellowship from the Canadian Association of Gastroenterology, did her PhD at McMaster University. Lucky for us, she came back to London, where she carried on training as a neurogastroenterologist at the Royal London Hospital and at UCLH. She's currently one of the GI physiology unit leads at UCLH and holds a number of consultant, honorary consultant, and associate professor positions. We're really, really lucky to have her here. So yeah, please, Natalia, take it away.
Thank you so much, Jeremy, for such a kind invitation and very kind introduction. And I must say that I'm impressed with how well you're pronouncing my surname. Just yeah, you just practice it once and it's absolutely perfect. You master it. So again, really thank you for inviting me, because in general, it is us gastroenterologists who seek, who need your advice in general, and it's a pleasure to share our understanding of one of the most complex conditions that we need to deal with these days, and very often we really need your support to help us with some of these patients. So let me see if we can, yeah. So I have started this presentation with a clinical case. I think it's easier for all of us to put ourselves in the scenario. Very likely we gastroenterologists will call you pain consultants and pain specialists to help us with this kind of patients. So this is a young girl who is 18 years old and has a year history of constant nausea and eating difficulties. She describes feeling constantly bloating, having pain, discomfort in the epigastric region every time she eats and drinks. As a consequence, she also suffers with early satiety, has reduced her oral intake, has lost quite a lot of weight, and her symptoms started after she suffered a gastroenteritis when she was traveling with her parents in Turkey. Her bowel symptoms have improved since then, but as I say, the pain and the fullness is really severe and preventing her from eating. When we examine her, she's bradycardic and she's hypermobile. There isn't anything abnormal in the abdominal examination, but for her cachexia and hyperalgesia, and her BMI is low. And she describes to us that even with a small glass of water, she already experiences abdominal discomfort. She then is too full to eat. She tries to burp as much as possible, constantly burping to empty her stomach so she's able to eat something. And there aren't any other symptoms. She's not vomiting. She feels nausea, but she doesn't vomit her food. There is no body dysmorphia. She wants to gain weight. The team has started nasogastric feeding, but the rate is very slow, 30 milliliters per hour, and she cannot tolerate a really tiny increase of 5 milliliters per hour. She, from a psychosocial point of view, she says that she deferred her A levels when her symptoms started, but as a consequence, now she feels isolated. She's not going to school. She's not sleeping well at night. She's not seeing her friends, and she feels quite low. So I'm sure I'm not describing a really unusual case. I'm sure that you have all been involved in similar cases. So the first thing is, what are the key elements of this dyspepsia pain clinical history, and what investigations are needed? And I'm sure that you will think, well, actually, as a clinician, I will be concerned about the fact that this patient has lost substantial amount of weight, is the substantial, quite a person is suffering with difficulties eating. There is an impact on the ability to function in every sphere of the person's life. The symptoms are impacting severely the person's quality of life, and there are also some aspects of the clinical history that suggest that the patient is quite sensitive to a very small stimulus. So those would be kind of the key elements of the clinical history. And the symptoms started after the gastroenteritis, and at the time she was probably a little stressed going through the A levels. So obviously, as you've noticed, because the patient has lost substantial amount of weight, there are alarm features. We want to make sure that we are not missing anything. The patient has persistent pain and has weight loss. So clinical scenario like this, where the symptoms are having some concerning physical manifestations, so there are some alarm features, we will recommend performing some tests. But in a patient of this age, it's very likely that and cross-imaging and an endoscopy will provide a low diagnostic yield, but they will be reassuring for us clinicians and for the patient and family. If the patient didn't have those alarm features, probably we wouldn't consider those tests. So then what is the diagnosis that this patient has? What is the strategy that we need to follow? Well, definitely we shouldn't say that the patient symptoms are in her head. We should carefully think if we need more tests. Probably with a cross-imaging and endoscopy, we have enough in this case to establish a diagnosis. And we shouldn't be saying we are not sure about the cause, because one message I want to convey today is that having very severe symptoms doesn't mean that the patient definitely must have an organic cause of the clinical presentation. So the patient clearly has functional dyspepsia, and we are all very familiarized with irritable bowel syndrome. Every patient we ask if they have ever heard about IBS. Most patients will tell us, yeah, of course. I know, I have friends who have IBS, or family members have IBS. But if we ask the if we make a diagnosis of functional dyspepsia, or we mention functional dyspepsia in the clinical appointment, very few people will be familiarized with that. And Jeremy and I, we were talking before about the fact that in spite of me doing this job for many, many years, I've never come across a patient coming to my clinic saying, "Doctor, I think I have functional dyspepsia." Most patients will say, "I have gastroparesis," very likely, or they will say that they have a pain that must be something organic, might be the cause of the symptoms. But functional dyspepsia is very prevalent, and we need to, and as in fact more prevalent than irritable bowel syndrome, according to the latest epidemiological study, and is defined as postprandial fullness, early satiety, nausea frequently present, epigastric pain, a sensation of burning, which is happening very frequently during the week for our patient, and it can impact significantly in the ability to eat, which is not so much the case for patients with IBS. So functional dyspepsia is one of the so-called disorders of the gut-brain interaction. These were previously known as functional GI disorders. And the functional GI disorders are classified according to criteria that a number of experts meeting every few years establish. And that classification is based on which area of the classification is based on defining those conditions on the basis of which area of the gastrointestinal tract the symptoms are emerging from. And there are a number of these conditions that are characterized by dysfunction of the organ, and other conditions are characterized by mainly pain due to visceral hypersensitivity and central sensitization. We have functional chest pain in the esophagus, or functional heartburn. We have biliary pain when it's coming from the gallbladder, functional anorectal pain, patients who have pain in the anal canal, central mediated abdominal pain syndrome, functional dyspepsia when the pain is mainly located in the stomach, and when the pain is secondary to bowel dysfunction, then we have irritable bowel syndrome. And it's really important to remind ourselves that disorders of the gut-brain interaction are really prevalent in the general population. And this epidemiological study that was published a couple of years ago showed that actually in Western world and definitely Europe and United Kingdom, the prevalence of any form of disorder of the gut-brain interaction, any of the ones that I've listed before, is actually between 30 and 40% of the general population. So we really need to think that the likelihood of our patients when investigations or clinical history suggests that the symptoms are due to disorder of the gut-brain interaction is very high, and therefore we need to introduce the concept really early in the clinical presentation. I think it's it's a mistake to run hundreds of tests and start and try multiple medications and keep saying we don't know what's going on. And then when we have seen our patients for 1 or 2 years, then we say, oh, well, we think this you have IBS. Well, I mean, that is actually will not validate our patient's symptoms. The patient will feel that because we don't know what's going on, we just went to the we use the resource of providing this kind of diagnosis. And if we feel from the beginning that the patient's symptoms might be functional, even if we organize some tests to be certain that we're not missing anything, we can introduce the concept at that point. Because the room for criteria for every disorder of the gut-brain interaction is really very well established, and the purpose is exactly that, is to help us to establish a diagnosis and provide a certainty to our patients. That is the point. And these criteria do not require to prove that there is an organic disease. We don't need to run 1,000 tests to establish the diagnosis. And it's key that we use a positive diagnosis. Your diagnosis is functional dyspepsia. You are suffering from functional dyspepsia, or you have the IBS, or you have functional abdominal pain, rather than, well, we are not sure, it fits, but we're unclear, it's possible. That provides uncertainty, and to patients that very often suffer from anxiety, and the lack of clarity of the diagnosis will only contribute to the anxiety about the presentation. And then, of course, there is when the clinical presentation is complex and the patient has severe symptoms, it's true that it's difficult sometimes to establish the distinction between disorders of the gut-brain interaction and disorders that are due to gut dysmotility. So, for example, functional dysphagia is difficult, might be difficult for us to distinguish if the patient dysphagia is secondary to functional mechanism, or is, for example, achalasia, if the patient has functional esophageal pain versus jackhammer esophagus, or similar, if there's a patient having functional dyspepsia versus gastroparesis, or bloating versus intestinal pseudostructure. So it's really key to know that with a careful clinical history, if we are well familiarized with disorders of the gut-brain interaction and these motility disorders, we are really quite likely to spot if the patient has a functional disorder or a motility disorder. And the discrepancy between the severity of the symptoms with very mild stimulus will make us think that very likely this patient might have functional disorder. A patient who has terrible dysphagia, drinking a small amount of water, is very unlikely that this is going to be achalasia. It's more likely that this will be functional dysphagia, and so on and so forth. But we gastroenterologists and neurogastroenterologists, we really have a number of tests that allow us to establish the diagnosis. So if you are uncertain, if you feel that there's a potential for missing a sensory motor dysfunction that is going to change the management of the patient, just involve a gastroenterologist or that is familiarized and is confident with these tests, and is so confident when to use them, when not to use them, and how to interpret, and very important, not to over-interpret those tests. And I think that this is really very, very important. And we have tests to measure perfectly esophageal motility and gastric emptying rate and colonic transit rate, and we are able to investigate the efficacy of evacuation, the sensitivity of the rectum to any stimulus. So we do have techniques that help us to establish if the patient has a functional GI disorder versus a motility disorder. So once we establish the diagnosis of that disorder of the gut-brain interaction, I think it's really key that we feel comfortable explaining the model in a way that resonates to our patient and that feels adjusted to the patient individual symptoms, because that is what the patient is going to. That is the moment when the patient is going to buy that diagnosis, and therefore to help to comply with the recommendations and to be able to implement the advice that we're going to provide. If the patient doesn't understand the model, then any intervention that we do, particularly any psychological intervention, neuromodulatory intervention, might not be helpful. So it's really important to spend time explaining the model to our patient, and also very important to perform a multidimensional assessment that I will explain in a second to define the strategy, the therapeutic strategy. So, for example, in a case like this, this patient has an event, a gastroenteritis, that might have caused some low-grade inflammation in the stomach. That leads to altered afferent pain signaling. So this, the way symptoms from the gastrointestinal tract, in this case the stomach, are being conveyed to the central nervous system is altered. But of course, if there is an underlying psychosocial history that is relevant, for example, environmental stress, or this patient was going through A levels at the time that things got worse, there is a history of early life adverse event, that increases the risk of developing anxiety, low mood, emotional arousal. So the patient is going to be very anxious every time feels the pain. And that will lead to negative emotions. Oh, there we go again, I have pain, it means that I can't eat, will be catastrophizing. And that will furthermore impact on how the central nervous system experiences the signals that are coming from the gastrointestinal tract. All that stress is going to affect how the autonomic nervous system controls the function of the gastrointestinal tract. It's going to affect motility, secretions. It's going to have an impact on gut microbiota, which will actually amplify the severity of the patient's symptoms. What is the patient will then engage in unhelpful behaviors, reducing food intake, avoiding certain foods to prevent the pain, leading to weight loss. So if we explain the model to our patient, I think it's a really, this example of explaining the biopsychosocial model to our particular patient can resonate with the patient's symptoms, and the patient can understand why it's feeling like that and why we are going down the route of a disorder of the gut-brain interaction with a biopsychosocial model. And I want to, and there's a concept that I really, really like to share with my patients to give them an example, because they say, doctor, you must be missing something, because it's not possible. With the severity of the symptoms I have, there must be something that is wrong. And I really like to explain to patients that how patients feel things changes a lot from one patient to another. There are patients that will have visceral hypersensitivity and others that will have hypersensitivity. And when I explain these examples, it really, really resonates to them. For example, patients with Barrett's esophagus versus functional heartburn, hypo and hypersensitivity, the competitive eaters versus functional dyspepsia, or patients with megarectum and megacolon versus patients with IBS. So let's go through that. So, when patients with a history of heartburn frequently are referred for an endoscopy, and I don't know if you're aware, but only a third of patients with reflux symptoms have an abnormal endoscopy. They have esophagitis when we do the endoscopy. And 2/3, when we do the endoscopy, have an absolutely normal and pristine esophagus. And there's absolutely no correlation between the severity of the symptoms and what we're going to find in the esophagus. There will be patients who will not feel anything at all, frequently Barrett's. They don't feel reflux symptoms, even in spite of being exposed to acid. And there will be patients who will experience terrible heartburn just with normal and physiological levels of acid. So then we have an example of hyper and hypersensitivity. Then we have competitive eaters. So these are people who in America they do these competitions where they eat gigantic amounts of food. And see who is the one who eats more food, and these are guys that in a study published a few years ago, this study showed that when the patients, the subjects, they were given some variant to look at what happened with their stomach, and their stomach was phenomenally dilated at the end of one of these competitions. Some of these guys would eat 36 hot dogs. And they would be okay. They wouldn't feel nausea or fullness. While some of us will have a little bit of a spicy curry, and we will be really very, very uncomfortable. So again, not everybody's gut sensitivity is the same. And similar with IBS. So this classic study putting a small balloon in the rectum and stretching it slowly has showed that patients with IBS to tolerate a very small volume of rectal balloon distension compared to controls. But then we have patients with megarectum and megacolon. I mean, that picture on the slide is a patient who has poop and has a rectum dilated and full of poo, and this patient didn't really feel anything. Came to the hospital because had some soiling and had been given by the way loperamide to prevent the soiling. So
basically the patient did not feel that it was distended with the stools. So explaining to our patients that some of us have a very sensitive stomach and some do not have a sensitive stomach can actually resonate to them. The other important concept is that of a multidimensional assessment. If a patient has stomach discomfort, is functioning, going to work, going to school, not losing weight, reassurances might be enough, but when the patient's symptoms affect on every sphere of their lives, then the approach needs to be different. So it's very important to assess not only to establish a diagnosis, okay, our patient has functional dyspepsia, but what is the impact on quality of life? What is the impact on nutrition? Is the patient suffering with coexistent anxiety and depression? Is there a risk of polypharmacy or invasive management? So when we establish that helps us to establish the appropriate strategy to manage our patients. Again, mild symptoms. We explain the model, we reassure, we provide some dietetic advice, we promote self-management. But if the symptoms are more severe, if the patient is losing weight, we might need to consider involving a dietitian who have expertise in functional GI disorders. We might need to consider neuromodulatory drugs to impact on to address the severity of the patient's symptoms, so involve psychologists who have expertise in psychological interventions that might be helpful in this context, and even in patients with severe symptoms have a multidisciplinary approach. So we establish the diagnosis, but also how severe those symptoms are in the context of the patient quality of life. So we decide, are we the right team to manage this patient? Do we need to escalate to another team? And again, we need to take into consideration if there are other conditions that are associated with altered pain processing that might be contributing to the severity of the patient presentation. For example, functional GI disorders frequently coexist with chronic fatigue or fibromyalgia, particularly in females, and there will be frequently coexistence of anxiety and depression, pain disorders, abnormal health-seeking behavior, sleeping disorders. So that all indicates that the patient is going to require a multidisciplinary approach. And this is particularly the case with patients with Ehlers-Danlos syndrome that are becoming more common in our clinical consultations. As you know, the most frequent of the Ehlers-Danlos syndrome is the hypermobile Ehlers-Danlos syndrome. And these are the vast majority of patients who attend a musculoskeletal clinic in rheumatology will probably have some form of hypermobility spectrum disorder. And there is this idea that patients with hypermobility, with Ehlers-Danlos syndrome or John hypermobility syndrome have the symptoms as a consequence of the stretchy connective tissue. And that is really unclear, because there was an interesting paper where patients with Marfan syndrome were compared with patients with Ehlers-Danlos syndrome and hypermobility Ehlers-Danlos syndrome. And the prevalence of functional GI disorders was much higher in patients with hypermobility EDS compared with Marfan syndrome. So it's not simply the stretchy connective tissue that contributes to the clinical presentation. And the prevalence of functional GI disorders is really high in patients with hypermobility EDS. And it's not so much, for many years, there was a lot of discussion that these patients have severe GI motility disorders. It is unclear that that's the case. And the evidence suggests that what they have is altered pain processing, a very high risk of disorders of the gut-brain interaction rather than profound gut dysmotility. And as an example, there's evidence in the medical literature that chronic pain, hyperalgesia is very frequent in patients with hypermobility, and the coexistence of pain, musculoskeletal pain, generalized pain, and gastrointestinal dysfunction is also associated with increased prevalence of psychomorbidity, particularly low mood, anxiety, and often actually atypical eating disorders. And in some of the patients that we see with the EDS and John hypermobility syndrome. The other important aspect I want to discuss is that most of us don't feel comfortable, at least in gastroenterology, explaining the biopsychosocial model. And that's why we really need to spend time at home when we are not with our patients, trying to develop a narrative
that we feel comfortable explaining. So when we are with our patient, we are not mumbling around trying to explain what is happening to the patient. Really have very clear in your mind what mechanisms you want to explain, how they are applicable to a particular cohort of patients, and in a way that convinces you, and therefore it can convince the patient. And there was last year, 2 years ago, this paper was published in Neurogastroenterology and Motility, asking UK trainees, gastro trainees, how comfortable they felt with the diagnosis and management of disorders of the gut-brain interaction. And you see how very often they didn't feel comfortable in the diagnosis, on communicating the diagnosis to patients. They didn't felt comfortable initiating neuromodulatory drugs. And this is really interesting, because we are talking about trainees who might be prescribing really complex drugs to immunosuppress our patients, and then they feel uncomfortable starting some nortriptyline or amitriptyline, or deciding if gabapentin is the right medication for our patients. So it's I think it's an area where most of us feel that we don't have the appropriate training, and we don't know actually when to refer the patient for psychological intervention, or what would be the appropriate intervention for our patients. And again, they felt that there were lots of barriers for managing patients with disorder of the gut-brain interaction. But, and of course, we will all recognize this, the biggest barrier was the lack of time to manage patients with disorder of the gut-brain interaction. These are not patients that we can discuss in 5 minutes in clinic. These patients require time, so we can explain that biopsychosocial model, we can reassure the patient, and we can assess them properly. The therapeutic approach, of course, is reassurance, psychosocial interventions, symptom management, and appropriate dietetic advice. And the one recommendation I give sometimes to our trainees is that, or to colleagues, is that if we don't feel comfortable, or we don't have the time in clinic to assess our patients from a biopsychosocial point of view, there are fantastic questionnaires out there that we can give our patients before or after the consultation, and then that we can actually use, and that's what I do. I mean, we have a system at UCLH where we send questionnaires to patients prior to the clinical appointment, and then we can say to our patients, okay, listen, your levels of anxiety are not very high according to our questionnaire, but your anxiety related to your symptoms, we use the VSI questionnaire, is very high. So that helps the patient to understand how the symptoms can trigger secondary anxiety, or how undergoing anxiety or low mood can contribute to the clinical presentation. And then it's easier for them to again buy the model and accept that maybe neuromodulatory drugs might be helpful. And during the psychosocial interviewing, as I said before, we need to assess the impact of the symptoms on the quality of life. We need to identify symptom-specific anxiety, so catastrophizing fears, anticipatory worry about symptoms trigger, preoccupation with the condition. Also identify behaviors that are unhelpful, being hypervigilance, modifying certain behaviors to prevent the symptoms. Multiple appointments to the doctors, or visits to A&E, using a very fear avoidance approach to food with an overly restricted diet or erratic eating behaviors. And then we formulate a biopsychosocial conceptualization. What are the predisposing factors, the precipitating factors, the maintaining factors? We identify those, we present those to the patient, and that can help the patient to recognize those and work on behavior modification. And it's very important to communicate all these observations to the patient in a way that is understandable for the patient. And of course, as you know, there are multiple therapies that can be used for the management of disorder of the gut-brain interaction. The majority of the studies have been done in patients with IBS, increasing number of studies also in patients with functional dyspepsia. But I think the key is for us to, I think we should be able to assess in clinic, is this patient, will this patient benefit from psychological interventions? And the first step is Is the patient understanding the biopsychosocial model? Is the patient willing to engage with psychology? There's no point in referring to a psychologist, a patient that is not ready. And also is a patient requiring behavior modification, then CBT is the right approach. Or is the patient having to accept that symptoms are what they are and needs to live with those patients, with those symptoms? Acceptance and commitment therapy might be appropriate. So there's different approaches, and we need to ideally work with psychologists that will help us to manage our patients. But all that work, introducing our psychology colleagues to our patients, needs to start in the clinical appointment with us. And we are not, we shouldn't refer patients to psychologists to get rid of the patient, which is what sometimes happens. And of course, that is a recipe for disaster. And I really, going back to the idea that neuromodulatory drugs are helpful in patients with these conditions, we need to really familiarize with neuromodulatory drugs and know when to use them, when not to use them, and use their side effects to our advantage. So, for example, patients who have quite marked anxiety and they have a tendency to constipation, well, we should be using SSRIs because they're excellent for anxiety and low mood, but they also, if anything, they tend to cause a little bit of diarrhea. In patients, for example, who have pain as the predominant symptom, but with a tendency to diarrhea, IBS diarrhea with abdominal pain and cramps, I like TCAs because they will address the cramps caused by the increased bowel activity, and they will constipate slightly, so they will address this IBS diarrhea phenotype. Patients, for example, where they don't respond to cyclic antidepressants and pain is the predominant symptom, maybe benefit from SNRIs. And patients with this increased use of mirtazapine, particularly in patients who have nausea, sleeping difficulties, and difficulties maintaining their weights, because mirtazapine helps gastric sensory motor dysfunction, particularly improves the sensation of nausea, improves appetite, and patients who actually have low weight, and we might need to actually consider a feeding tube. Mirtazapine might be instrumental in preventing that, and we're using mirtazapine quite a lot in our patients with nausea, with severe difficulties eating, a lack of appetite, and very often prevents us from using a feeding tube. And of course, it addresses the anxiety, which is one of the mechanisms that contributes to the clinical presentation. And just the last few slides, again, recognizing that in patients with severe disorder of the gut-brain interaction, the prevalence of using polypharmacy is very high compared to other patients with chronic conditions, particularly neuromodulatory drugs, that they need to be used appropriately, and interestingly, benzodiazepines and opioids. And of course, if we, in this study that we published some time ago, we analyzed 100 patients with disorders of the gut-brain interaction that have been referred to our unit, and the prevalence of opioid use in those patients was 20%. So we're talking about patients who don't have any organic disorder and have a very high dose of high prevalence of opioid use. And the patients who were on opioids were at higher risk of requiring advanced nutritional interventions like enteral feeding or even parenteral nutrition. And that risk was higher in patients who have an underlying diagnosis of depression and hypermobility EDS. So we have patients whose gut motility might not be completely perfect, and then we're giving them anticholinergics, opioids, which of course will cause gastric motility dysfunction, will contribute to constipation, will cause palpitations, and these patients will then will be concerned about pulse and palpitations, will cause bladder urinary retention. They will need to be catheterized. So before we realize, we have a patient who part of the symptoms that the patient is experiencing is a consequence of the medication that we are prescribing to our patients. And the last few slides are about the relation between the patients with severe disorders of the gut-brain interaction, and coexisting psychomorbidity, particularly somatization and high levels of anxiety, are at increased risk of developing a restrictive pattern of eating, and the number of self-perceived food intolerances can be very high in these patients. There is increased evidence that avoidance, restrictive fear of eating is quite prevalent. Is becoming more evidently prevalent in patients with IBS, also with patients with functional dyspepsia, and of course, all of us, when we feel a stomach discomfort, we're not going to be eating normally. But when the degree of food avoidance is concerning, when there's low BMI, where the patients need to be admitted, we need to explore if the patient is really engaging in patterns of eating, of food restriction that are dangerous, and we need to reverse that with the appropriate psychological intervention. And ARFID is different than anorexia. A patient with anorexia is going to be, there's going to have a distorted body image, distorted body shape, is going to be obsessed with exercise, is going to be obsessed with calories and portions. What our patients with ARFID, the main problem is that they will have a fear of adverse symptoms experienced when the patient is eating. For example, some patients will not eat because they have fear of choking, or fear of vomiting if they eat, or abdominal pain. And this is, as you know, there's 3 types of ARFID: patients who don't eat because they have no interest in food, patients who restrict their eating because they avoid certain textures or colors or smells. But the ones that we see in gastroenterology are those patients who restrict their eating because they are worried, they have real fear and phobia of the symptoms that the eating is gonna trigger on them. And I'm afraid there aren't these days good pathways for managing those patients. So in conclusion, we all, carers, family members, dietitians, psychologists, doctors, we all really need to have play the same music, and we need to have a patient-centered approach, but we have to provide a positive diagnosis, establish a multidimensional assessment that tells us who should be managing this patient, which health professionals need to be involved. We need to be really familiar with the medications that we use in these patients, and be familiar with the potential psychological interventions and dietetic interventions, and when to use them and when to introduce them to our patients, so we can provide, we can avoid iatrogenic harm. We can help our patients to get better. Thank you. That's all.
That's brilliant. Thank you so much. Virtual round of applause. We're going around there. Thank you so much for that. Right. So, look, we've had some action in the chat box. I think there probably will be people doing more thinking and responding as we go through. So let me start off with a couple of questions that have come up on the chat. And the first one is a delightful question that's, I think, very much about clinician behavior, I think. How do you stop doctors doing an endoscopy just in case?
So the first question is, why do we do the test? Are we protecting ourselves, or are we reassuring our patient? If we try to protect ourselves, we need to remind ourselves that there are clear criteria that indicate when tests should be done. And therefore, if the patient doesn't fulfill those criteria, we are safe. I know that we practice a very defensive medicine, but we need to remember that algorithms are there to also justify our decisions, number one. Regarding reassuring patient, this is an interesting point. There are lots of studies that show that repeating tests only contributes to perpetuate uncertainty about the results of those tests. If there isn't any change in the symptoms since the last test was done, if there isn't any alarm symptoms, we need to break the cycle. And it is also our responsibility to say, if a patient had an endoscopy a year ago and there's nothing that has changed, it's absolutely not rational for repeating the test, and particularly in certain age cohorts where the likelihood of pathology is very low.
Thank you. And I think if we just stick on the theme of clinician and service behavior for a minute, I'm kind of interested in following that one with a question that's just come in. Reflecting on receiving referrals into a pain service that has really no interaction or integration with the gastro service. How are we going to do in managing abdominal pain effectively in those conditions where there's no crosstalk between the two?
Well, for example, at UCLH, we're very lucky that the physiology unit, we have gastropsychology colleagues working with us. And one of the criteria to accept patients is that these patients cannot be they cannot be waiting for a test. All the investigations have to be finalized before the patient is referred to gastropsychology, because and the other criteria is that the patient has to accept the referral and the diagnosis of a biopsychosocial model and a functional diagnosis. Well, there are two from the pain perspective, and I'm sure you can correct me if I'm wrong. There are two types of approaches: interventional approaches that you can guys use using different medications, different topical treatments or injection-based treatments, but then we have the behavioral and psychological treatments. So I don't think a patient should be referred to biopsychosocial model management of pain without consultant-to-consultant discussion or register-to-register discussion. Because if the patient is not ready, if the patient is a waste of time for the patient and it's a waste of time for the clinical team. So there has to be a dialogue, an open dialogue, and I think that and that's when services benefit and patients benefit from interventions. Sending a patient to the pain team because we don't know what else to do, probably that's not appropriate, isn't it? Mm-hmm. I saw a patient this morning actually that she is absolutely convinced that I'm missing something, and she asked me to refer her to the pain team. I said, because the pain team at UCLA has a very biopsychosocial model, and said I can't refer you to the pain team because you feel that I'm missing something, so you are not going to benefit from that approach. And sometimes we need to say I can't help you anymore. And that was the process. I can't really help you anymore. And we are not going to do any more tests. There's no point in doing more tests. And this is the model that we are going to that we recommend. Let us know when you are ready. And I think and it is our responsibility to work collaboratively with our colleagues. Yeah.
And so then if we go out to a larger sort of profession-based view and professional body-based view, how well do you think we as pain clinicians and pain bodies are good at working with you as gastro people? Because I'm very aware that the pain community has come up with the ICD-11 diagnostic criteria recently of chronic primary pain symptoms, functional pain symptoms. They don't seem to have a lot of relationship to the very sophisticated Rome 4 criteria. Do you think that we as pain clinicians are paying enough attention to what's going on in your world?
I don't know. That is a big question. I think the main problem is that in order to have, I'm sure all pain specialists are aware that some patients' pain has characteristics that mean that they will not benefit from certain pharmacological or invasive interventions. We all know that patients with nociplastic type pain is not going to benefit from high doses of opioids. But very few services, pain services, particularly unfortunately in district hospitals, have access to they can count on allied health professionals that can help them, psychologists and so on. So and we clinicians, I think we all want to help our patients, and when patients are referred to us and we don't have access to clinical psychologists or behavior or OT or behavioral or CNS that can provide behavioral support for our patients. If we don't have that, so we all want to help our patients, so we'll feel inclined to do something. And sometimes doing something means, okay, let's just try this new medication. Let's just try this new intervention. And there is this, I think because we all really want to help our patients. We very, very, very rarely say, I can't help you, or I don't have the model. Also, we know that tertiary centers might have access to those services, but very often these tertiary services require that as the patients are being seen first by secondary or district services. So we are inclined to try everything, and then if it fails, move to the next. And so the way services are set up is probably not appropriate for this cohort of patients. We know that patients with chronic pain, who have had suffered with pain for years, don't benefit from more drugs and more. They don't, and yeah, but we don't have. Most of us don't have access to the services that will benefit our patients. So we feel inclined to do something, which is not always the appropriate thing.
Mm. And we've just talked a lot about secondary and tertiary services, and a question's just come through about pushing this down to the end of primary care services. I mean, is it impossible to imagine a world in which GPs would do some of this explanation, or is somebody always going to get referred to a specialist to get this level of biopsychosocial kind of approach?
As I mentioned in one of the slides, if patients have mild symptoms that don't impact on quality of life, that should be managed at primary care level. And even probably patients on the second level should be also managed at primary care level. There should be community hubs where actually similar to you know diabetes management. Even complex diabetes can be managed in primary care with a group of physicians or a group of primary care professionals that have an interest in the management of these patients. So it doesn't need to be seen. It doesn't need to be managed in the hospital, but there has to be a hub, and the hub is not just the GP on his or her own.
Yep.
That's impossible to do. It has to be a hub where you have the GP, the psychologist, the OT, the specialist nurse providing education and support. We need that model in primary care, and only the very complex cases where there is nutritional factors involved should be managed at hospital level. Yeah, but it's not just it's too complex and it requires too much time for just being left on the hands of the GP. That's not possible unless symptoms are very mild. Yeah.
Yep, that's definitely the kind of aspirational service which would work best, doesn't it? I mean, we have had one very specific question come through about an approach called NERVA,
Oh, yeah.
NERVA. Yeah, and just I'm interested asking your views on that.
I like Neva a lot. Yeah,
Could
absolutely.
you explain it to those of us who may not
Yeah.
know
So
much about it?
Neva is an application that is an app that was developed by if I'm not mistaken, by Monash University in Australia, and provides that is for the management of patients, of self-management of patients with irritable bowel syndrome, and has very helpful information around disorders of the gut-brain interaction, dietetic interventions, and has a fantastic gut-focused hypnosis program. And I have to say that I have recommended Nevas for some of my patients with mild, moderate symptoms who actually want to who are motivated and they really want to do things. They don't have too much time, and they want to self-manage, and people who have quite a degree of good self-efficacy, and they have found it really helpful. So there is a role for NEVA for patients with mild, moderate symptoms. And I have to say that sometimes I have had patients who wanted to use this kind of information, and they didn't have IBS, they have functional dyspepsia, and I've told them, listen, use the gut focus hypnosis, use the education of this application. The dietetic side of things might not be very applicable, but and they have found it very helpful. But particularly for IBS, it is helpful. I agree. Yeah, and there is evidence behind the use of NEBA. It has been published. They published in the American Journal of Gastroenterology quite recently. The outcome of the intervention in patient is quite positive. Yeah,
That's great, thank you. And it's really useful for us as pain clinicians to hear about things like that, which are not necessarily front and center in our world. And so you did mention in terms of standard questionnaires a number of things which we're familiar with, the GAD-7, the PHQ, and then you came across things like the VSI, Visceral Sensitivity Index. Could you
Mhm.
just give us, as people who are outside the gastro world, a tip on what the ones you enjoy are and what you would encourage us to explore?
Yeah, I love VSI. That's
Mm,
actually my favorite one because very very often patients with disorders of the gut-brain interaction, the mood might not be necessarily low, or they might not even recognize that they have low mood, or they are particularly anxious. But what they do, the big difference from my perspective in the management of these patients is when I see that the patients are really, really fixated and vigilant about that particular region of the body that is causing the symptoms. So it will be about do you think about your stomach before going to a restaurant, or do you does your stomach symptoms prevent you from engaging with friends? So they are questions that basically highlight how that particular how those symptoms influence every sphere of the patient's life. And 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 it's really helpful when to show patients, look, you're not very anxious, but actually your VSI score is really high, and it means that you're very vigilant. You're really worried that the symptoms are really interfering every aspect of your life, and that's why. If we use a gastropsychology intervention to reduce awareness, to reduce hypervigilance, that would be very helpful. Or we can say if we use neuromodulatory drugs, that might make that sensitivity in your gut and that awareness and hypervigilance be a little less intense. So, and then actually they recognize that because we're not saying that they are anxious or this in the head. We're saying that the symptoms are causing anxiety, and people are more likely to recognize that anxiety is secondary rather than the primary mechanism contributing to the symptoms. And it's it's a really nice way to engage the patient with the symptom management.
Brilliant, thank you. Well, I'm beginning to think we've taxed you with enough questions, and we've definitely got our money's worth in terms of getting your responses. So thank you so much once again, Natalia, for that. That was really, really useful. And I think hopefully this will have influenced a small tranche of pain clinicians and made us a little bit more switched on to the functional GI problems. So
Can
thank you.
I, Jenny,
Please, good.
can I make just one comment? I saw a question about how to get funding for creating the services. And when I first came to the unit, we didn't have gastropsychologists, we didn't have gastropsychiatrists, we didn't have neurogastrodietitians. And what I did was I was auditing how much some of our patients how much time they were spending on the wards, the cost of those patients that were not properly managed, the number of follow-ups that were required because we didn't have access to psychologists. And that's so proving to the trust that it was really expensive not to have that allied health professional was the way. And actually the current international recommendations is to have that kind of model was the way to convince our managers. Yeah.
Thank you, and thank you for picking up on that question. It's much appreciated. I know certainly that if the people who attend A&E frequently in our local area, the gastro and pain patients are very much up there. Right. Well, thank you, Natalia, once again, and it's nice to see the thank yous coming through on the chat there. Appreciate that. So just allowing me to wrap up, then please do stay in touch, everybody. We will put all of the future pain forums out on Twitter, but we've also got or X, my apologies. We've got a newsletter and that will come out, and a mailing list. So we will do a post event email, which will have the video link that will have our email on it. So if you want anybody else to be hooked up and on the list for the emails, then please do that. We did mention, I'm going to do a shameless plug now. We did mention acceptance and commitment therapy. Here at BCPS, we are still taking people on for a really hardcore 2-day experiential training event in acceptance and commitment therapy coming up in May. So if any of you out there are really interested in a deep dive into a psychological model, which is quite hard work, lots of experiential work, lots of role play, and we've kept it face to face. We think that's really important. It's not online. Then do have a look at the website. But in the meantime, thank you all very much, and we hope to see you at Pain Forum again soon. Thanks a lot. Bye bye.